right, here we go. Oh. Whose idea was it to film this? Today we're taking a look at some basic airway adjuncts, which are some tools that we can use to help keep a patient's airway open if they have a severe injury or are unresponsive. As always, this video is no substitute for medical direction or actual medical training. I'm just another guy on the internet that is throwing some facts out there and some information regarding some products and some training. So always seek out proper professional medical training, seek a doctor if you have specific medical questions, and do your due diligence in research regarding particular topics rather than just taking one person's opinion on things. So let's talk a little bit about airway adjuncts. Well, an airway adjunct is some tool that we can use to help hold an airway open. We do an assessment based off of ABCs, airway, breathing, and circulation. And these three things are critical. Or if we're using the March algorithm, we have massive hemorrhage first, and then airway, respirations, and circulation. So airway is of utmost importance, and we have to maintain an open airway, especially in an unresponsive patient. So we have some tools that we can use to do these things, but I think there's some misinformation going around about some of these tools. So we are going to dive into that and see if we can get to the bottom of some of this today. So two basic airway adjuncts we're going to look at are the NPA, or the Nasopharyngeal Airway, and the OPA, the Oropharyngeal Airway. The difference between these, one goes in the nose, one goes in the mouth. But there are different times you use these, and some patients that may be able to tolerate one and not the other. So let's talk about the NPA first. The NPA comes in different sizes and also a lot of different brands. So I have several different brands here, and while these are all NPAs and can all be used the same, they just look a little bit different in how these are actually put together. Now, while there are a lot of different brands, you have kind of two main styles. Most of these brands are this PVC style. They're a little bit tougher, a little bit more rigid, a little more stiff than one of the other types, but they do the job, they work well, and they're typically a little more cheaper than the Teleflex one. So the Teleflex is pretty common. You see these on the ambulances a lot. The military first aid kits and IFAKs and stuff that you get usually have this brand. I'm not sure why it became so popular, but it is a little bit more flexible than these other PVC ones. It's not quite as rigid, and so maybe that's the idea, is that it bends with the curvatures of your throat a little bit better. I've used both of these, haven't really had an issue. The main thing is sometimes these stiffer ones tend to slide back out, but I've had both of these slide back out. So it's a good idea once you place one to tape it down a little bit just to keep it from working its way out over time. The basics of an NPA are that it will slide up your nose, it goes down to the back of your throat, and it allows a passageway of air from your nostril down to your throat, close to the glottic opening where your trachea is, which allows air to get down to your lungs. So if I'm laying on my back and my tongue flops to the back of my throat, it could occlude my airway. If I slide an open tube from my nose down my nasal passages to the back of my throat, and now I ventilate, or the patient's breathing, then they can now move through an opening, or this open channel, rather than the tongue occluding that by falling on the back of the throat. To have these NPAs work, though, we have to make sure we size them correctly. If they're too long, they may go down to the esophagus, down into the stomach, and now when we ventilate, we're actually just pumping a lot of air down to the stomach. If they are too short, then they're not going to reach long enough to get past the point where the tongue is actually causing an occlusion, which is what we hear when we hear snoring or snoring respirations. That's the tongue on the back of the throat and air trying to move past that tongue. So by putting this down there at the correct length and depth, we can now bypass that, but we can't go too far, so sizing is critical. So the sizing in these is in French. So French, with the higher number in French, the larger the actual diameter is. If you have a gauge like a needle, the smaller the number, the larger the diameter is. It's kind of like a shotgun gauge as well. 12 gauge is bigger than a 20 gauge. Same thing with needles, but French, it actually, the larger the number, the larger it is. So typical sizes would be anywhere from 22 to, let's say, 36. 36 being quite large. 28's right in the middle. And that's the typical size for a normal 5'10" to 6 foot person, and that's why 28 French is most of what the military carries. If they have an IFAC, they take a 28 French, and most of the time that's just what gets shoved in there. Then your medics, or especially on the civilian side, your ambulances and hospitals, they're going to have a wide variety of sizes to choose from to make sure that it's paired up specific to that patient. All right, so the way that we size this up is we are going to use some external landmarks to estimate where this would end up once we put it internal. So we're going to go from the nostril, the nair, where this would be sitting, and we're going to go around to the earlobe. So from here to the earlobe, or from this side to this earlobe. And once you find a NPA that is the correct size there, we're going to assume it's going to be pretty close on the internal anatomy to be able to sit where it needs to in the back of the throat. Once you've properly sized up your NPA, you add a little bit of lube, you slide it down, wiggling back and forth to be able to push it down in there. Make sure this flange goes all the way up to the nair, and then use a little bit of tape or something to secure it. Just make sure you don't occlude the hole. If you want some further information on how to put one of these down, we'll leave a link to our airway video in the description below. You can see that video. It goes into a lot more detail than we're going to go here. This is more of just a product overview. All right, so a couple considerations when using an NPA. If someone has severe facial trauma and a possible skull fracture, we want to be careful placing this, because the idea is that they could take an NPA, you could shove it through a place where it's not supposed to be, because now there's a fracture in the skull, we could end up in the brain, we could cause more damage. Now, I don't believe there's any documented cases of that happening. At one point, there was a French catheter, a suction catheter, which is much, much smaller than this, and it did some damage. So because of that, they kind of freaked out, said, hey, watch out, we're putting these in people with head injuries. So we do want to make sure we do due diligence, though, and make sure that they don't have any massive open fractures or skull fractures. And always make sure you're following your local protocols before placing one of these. Let me just stop for just a second. If you find any of this information, this video helpful, leave us a like on this video. That would really help us out. If you have any questions over the stuff we're talking about or any of these specific products, leave us a question down below. We'd love to hear from you, and we'll answer it to the best of our ability. And if you're not already doing so, subscribe to the channel. We post content on a regular basis, and make sure your notifications are on so you get alerted when we post any future content. Our next option would be an OPA. Again, this is one of our simple airways before we get into something like a King airway, a LMA, iGel, or even endotracheal intubation, which would be a paramedic or a doctor skill typically. So this basic airway adjunct, we take one of these OPAs, we slide it down in the mouth of an unresponsive person, and we rotate it into place so that this curve now matches the curvature of their throat. This flange on the top side here will sit right above the teeth, and then this curve will go and help hold the tongue off the back of the throat. And these passages down the side will also allow for airflow from outside ambient air down through the oral cavities and down into the trachea. So as opposed to the NPA, which is now allowing a passageway through the nose, we now have an OPA, which is allowing a passageway through the mouth. Now with these OPAs, we don't have to be as concerned about patients with skull fractures because we're not shoving this back into their nose. We're just putting it down their oral cavity, helping lift the tongue a little bit, and it works great. These are really beneficial to help with a patient that may have some snoring respirations, but the downside is these patients cannot have an intact gag reflex. If this patient is semi-responsive, an overdose patient, someone with a head injury that may still have a gag reflex, we have to be careful with these OPAs. We put those down, it'll trigger a gag reflex, they vomit, and now we have an airway compromise issue because of the vomit. And if that vomit gets down in the lungs, we could have further complications from that very acidic aspiration from the stomach juices that have now come up. So because of some of the complications with the OPA and having to make sure a patient is fully unresponsive and does not have an intact gag reflex, this limits the amount of patients you can use this on, which makes one of these a little bit more of a popular option for someone that's severely wounded, maybe in and out of consciousness, is lethargic, but someone we want to maintain an open airway on. So because of that, the military has put a 28 French NPA in most IFACs. And so the idea is if you have a casualty, you go ahead and place one of these, and if they go unresponsive from lack of blood, from a tension pneumo, or from whatever the injury is, you now have an airway in place. Also, if you have a patient that's already unresponsive, even if they don't have an intact gag reflex, we can still put an NPA down to be able to help hold that airway open while we're treating them and evacuating them and getting them to a safe place. Now, because these are TCCC guidelines for airway management and using NPAs, we have to remember what setting we are prepping for and what scenarios are we setting our medical equipment up for. Now, I don't carry one of these in my ankle kit. I have some trauma supplies, but this is one thing I don't carry. A lot of people carry this in an ankle kit. They keep them with them all the time. They say, well, the military needs it in their kit, so I guess I need it in mine. Well, you can lift the tongue off the back of the throat with some manual manipulations. You can do a head tilt chin lift. If you're worried about a spinal issue, you can do a jaw thrust, which is displacing this jaw forward. And when you move that, it lifts the tongue up, allowing air to flow. The only downside is now I have to use my hands for that manual airway manipulation, and I can't go do something else or move to another patient. With the equipment that I carry on a ankle kit, I can't treat a large amount of casualties. I have enough for maybe one person. If that person is hurt in multiple places, I don't even have enough to treat one person. I can address one injury of one form, basically. If I've got a single pack of quick clot, one pressure dressing, one or two chest seals, one tourniquet, I'm not going to get very far with that. So if I'm planning to treat multiple patients, having one NPA is not going to do me a whole lot of good anyway, because I'm going to need multiple. Another scenario would be I'm carrying this to treat one patient, one single injury, one-off event, whether it's a car wreck or I happen to be somewhere when someone gets shot or injured, and I'm now going to use this kit to treat them, which is most of the time what I'm carrying this for, is to be able to help and render aid to other people. If it's a single person, I can do the same job that an NPA would be doing, except do that manually with manual manipulations of the head. I can do a head tilt chin lift, or if I'm worried about cervical spine fractures, I can do a jaw thrust, which is literally just displacing the jaw. By putting some pressure, the jaw moves forward, lifts the tongue, and allows a passageway for air to be able to go back and forth. So those manual manipulations are something I can do, and I could even teach a bystander how to hold the airway open to maintain that open airway, which would be probably even better than if I just crammed one of these down and then left the patient alone. I could also roll this patient into recovery position, which then, instead of gravity pulling the tongue back to the back of the throat, they're now rolled forward, their airway's open. If they did vomit, now all that vomitus would actually go on the ground. The tongue is being displaced forward by gravity, and so that's a great position to leave someone in too if you have to start moving and treating multiple patients. Now, when we talk about an IFAC, originally an actual IFAC, an individual first aid kit, was something I carried on me with medical or trauma supplies to treat me. They were for teammates to come up to an injured soldier and be able to take their medical gear off of them and be able to use them on that patient or that soldier themselves. You always use that person's kit on that person. That was kind of a military tactic. It's a great tactic for everyone to carry all the supplies needed to treat themselves. Everyone spreads that load out rather than one medic having to carry everything for the entire team. So you go to a casualty and you know there's going to be tools there to use on them. Now, if I'm using that idea to have an NPA that someone can use on me if I get injured, well, that's a good idea. But the downside is the people with you have to know that you have one on and how to use it. So if I'm out by myself running errands, which is most of the time when I'm using an ankle kit and conceal carrying, I am now walking around. If I were to get injured or shot, the likelihood that someone's going to come up and think to check my ankle for medical supplies and then pull an NPA out of the ankle kit and then know what to do with this little plastic tube to be able to save my life is kind of not realistic. So if we're carrying in an ankle kit, because I like to conceal it most of the time and try to blend in with my surroundings, I don't typically cram it with a bunch of unnecessary stuff. I keep it really basic. I don't put NPAs in there. I do have NPAs and OPAs in multiple kits that I own. I keep them in the car when I go on long trips. I've had to use some of these things on wrecks that I pull up on to be able to treat patients, but I don't carry them in a ankle kit. These would be better suited if you had a team that was working together, especially going outside away from readily available resources. You wanted to put some of these in there. So if you had to package a patient in some sort of a stretcher and hike them out, you could drop one of these down to make sure they have some form of open airway, because you can't manually do airway manipulations while you're evacuating them, especially if you have them wrapped up in blankets on a stretcher that's improvised. You may not have proper head positioning. So this gives you a little bit more peace of mind to try to keep that airway open. That would be a great use case for it. but throwing one in your ankle kit or in your pocket to carry on an everyday basis might not be the best use of resources. Everything we've talked about today, the NPAs and the OPAs, are available on our website at 6ecosystems.com. We also stock these in our responder kits, which you can find on the website as well. As I mentioned earlier, we did an airway video earlier that went in a lot more detail regarding using an NPA, an OPA, manual airway manipulations, and even rolling someone into the recovery position. So I would highly recommend you checking that video out. Again, there's a link in the description down below. Take a look at that video and you'll get a lot more information than what we put in this video. Well, that concludes this video. I hope you found this information helpful. And as always, stay vigilant and stay safe. Whose idea was it to film this? That's comfortable.